that we don't know. For instance, for example, our program, the SWAP program in University of Manitoba, we work with MSMs, although we've worked with the female sex workers for 30 years, over 35 years now, I think, and counting. We've only been working with MSMs from 2009. And unfortunately, we've been very successful in terms of enrollment of MSMs who are actually in sex work. And a few from the community who are actually in sex, but you have to, in a way, take a leap of faith to kind of be linked with the other group of sex workers. And you can see from the graph, the numbers have actually been steadily increasing. We have about 2,000 now. It's just under 2,000 currently. But these are the active ones because people go and and come back. We use biometrics to actually know who exactly is on board, and you can see we've actually maintained a very clear number in terms of enrollments. But that doesn't talk about the population because one, we are enrolling more sex workers, and you want to have a global picture about the community. And sex workers, again, by design or by default, have a high HIV prevalence, about 32, as at the moment, and that because they're at higher risk. Like looking at the group that we're actually working with, and also incidence is actually very high. And so we decided to find out exactly what is happening in the general MSM community in Nairobi County, and that is how the Transform study was mooted. And we were lucky because this study was supposed to be done in Dar es Salaam, and somehow happened that it couldn't be done in Dar es Salaam because of politics. So it was actually done in Nairobi and in South Africa. So there are results for Johannesburg and results for Nairobi, but only focus on Nairobi. And the aim for the study for Nairobi was to describe the unmet need for prevention, diagnosis, treatment for HIV among MSMs in Nairobi County. So it doesn't talk about sex work, this is general MSM, and to determine acceptable programmatic responses to these needs. We had 4 objectives. One was to estimate, specific objectives was to estimate the size of MSM population in Nairobi County and to describe online and physical networking characteristics within these populations, to estimate the prevalence of HIV, hepatitis B, hepatitis C, syphilis, genital, rectal, pharyngeal, neisseria, gonorrhea, and chlamydia trachomatis infections. And we also plan to document the current continuum of HIV diagnosis, treatment, initiation, individual virological suppression in this population, and finally to determine individual community structural enablers and deterrents to engagement with existing and novel HIV preventive, diagnostic, and treatment services. So in a way, it's a mouthful, but at least that is what we intended to do. And I would say that we were successful because between October 2016 and February 2018, we were actually able to do this and complete the study successfully. For Nairobi, we did the study in phases. So phase 1 involved in-depth interviews with MSMs who were very carefully selected. In terms of education level, socio strata, like typologies, because there are different types of MSMs. And we did in-depth interviews with about 30 of them. And in the in-depth interview, we kind of focused on prevention, testing, treatment experiences and barriers of the individuals, of that individuals, their knowledge, acceptability of existing and novel prevention interventions, their on and offline networking, preference for receipt of prevention, testing, and treatment, where they actually prefer to go. And then that was followed, by a phase 2 study whose sample size was about 600. And this was, we undertaken it through a respondent-driven sampling. And again, I'd like to report very early on that these were very successful because using 10 seeds, we were able to enroll 608. And the inclusion criteria was current male gender identity or assigned male gender at birth. They had to be 18 years of age, older. That's the age of consent in terms of informed consent in Kenya. Resident of within 50 kilometers of Nairobi County. They've had to have had consensual oral or anal intercourse with a man at least once in the last 12 months. I know other people, use maybe 6 months, but we actually decided to use 12 months. And these individuals who came for, who were recruited through RDS, had a computer-assisted personal interview survey that kind of focused on HIV testing, treatment, monitoring of care, HIV transmission knowledge, perception of risks, sexual behavior, substance use, chemical sex or chemisex, knowledge and use of PrEP, their online social and sexual networking, the existing social support networks, experiences of discrimination and abuse, which is actually very rampant in our area. And we also did audit and PHQ-9 for mental illnesses. And then the individuals who actually participate in the respondent event sampling, we collected blood samples. These were subjected to rapid HIV testing at the clinic level, and then we took some of the samples for like qualitative and quantitative RNA, and a sample of the negative was actually kind of subjected to the same to actually confirm the actually negative, and eventually maybe you might actually do post sequencing. We also tested the blood, hepatitis B in the blood sample, hepatitis C. We also did RPL and TPHA on the blood sample, and especially the ones who are positive for RPL. And the urine samples and pharyngeal samples actually subjected to PCR, gene expert PCR. And urine was actually self-corrected, pharyngeal samples were corrected, and rectal, there was an option of self-collection, but I like to say very, very few opted for the self-collection, and most of the samples were actually collected by the clinician at the clinic. Let me start by saying that this study was very successful because of a very effective stakeholders engagement, and we realized it was actually key to the success of the project. We had GARC, HOIMAS, ISHTA, very, representatives very, very involved, and they even advised in terms of the phase 1 recruitment, phase 2 recruitment. They also had, kind of looked at the instruments that were used. They helped us in terms of as community liaisons, and we also kind of talked to NASCOP team, and we also talked to the Nairobi County team. So they were actually informed before the study began. When the study was going on, we ensured a very active community representation with meaningful involvement of the community members. They actually manned the front desk. They had to do the day-to-day liaisons with the CBOs and etc. They also talked to their, the community members in terms of referral networks, and they also kind of supported in terms of mentorship and mentoring. And this kind of contributed to the success of the program. And anybody working with the MSMs, if you don't include the community, I don't think you'll actually go very far, from my experience. So in terms of recruitment enrollment procedures, it was very, very simple. We had, in terms of now the RDS, we had identified the seeds from the community itself, and they had to be, we had identified the 10 seeds of diverse education background, social strata, because you have to have the rich and the the middle class and the poor. And different topologies, depending on the tops, the bottoms, and the, let's say the versatiles. We had to kind of have a mix of them, and even the tribal representation, and make sure at least all sub-counties of Nairobi were actually covered. And once we picked one of the potential a seed or participant, then we would actually undergo eligibility checks. We had to confirm they actually are eligible for the study. Then they had to give us informed consent. And at this point, I also like to mention that at least we were able to use biometrics to ensure at least there were no repeats, because it actually happens a lot in our settings. The individuals who actually passed to that particular check then went to the second part of the study, where they actually did a self-complete electronic survey, or the CAPI, the computer-assisted personal interview. And this was adopted because we thought that there would be the whole issue of the face-to-face, the personal interactions, because we thought at least with a computer, then you'll be able to be yourself. And there were a few challenges here and there, but at least we got the right information. And then once the individuals complete that particular part, which took about, it was a little bit lengthy, maybe 1 hour, 45 minutes to 2 hours, then they would go for the testing with the counselor. Then they would actually get on-the-spot results. We had a clinician on board. Then they would go and get a physical examination. And whoever had a problem then would be treated. And whoever required referral would actually be referred. Then there would be clinical specimens collection by the clinicians or the clinician, and this will be now taken to the laboratory. And then the individual, after that completion, then will actually get a reimbursement, which was at 500 shillings. And then the individual will actually get 2 coupons, and were advised to go and give them to their friends, and especially their sex partners and people they knew apart from the community. And if you look at the number of recruitment, the A12112112, you can see they were given coupons that were actually very, very similar to their number, but then were given coupon number 1 and number 2. That is how we were able to track them. And as I said, that was very successful, and reaching the hit population. And within, let's say, 7 months, we were able to recruit 608 participants from the 10 seats. From the from the slide, you can see very successful seeds, but you can see some 3 that were actually not very successful. This one didn't yield much, and you can see this one only yielded 2, and F didn't do very well. But at least that's exactly what you expect from RDSs. And the ones that didn't do well, I think we had one that we wanted to kind of penetrate the Somali community, the Indian community, and the others are from the upper social strata. And those ones performed very, very well. And out of the 10 seats, we're actually able to get more than 608 participants, because you can see another group of 153 that were ineligible, and you can see why they were actually ineligible. And of interest is that individuals even photocopy the coupons. Through the biometric, we're able to kind of exclude some actually who actually wanted to come in for a second time, because sometimes you can forget the faces and the names, and you can see a battery of issues in terms of ineligibility. But at least what I like to say is that we actually got a representative sample from the community. Now I'll shift gears and move on into the general results, the ones that I promised to present. In terms of social demographics, we enrolled a very young population. You can see median age of 26. And at least under 30, you can see there are more than, I'd say it's about 78%. MSMs in Kenya tend to be very, very educated compared to the group that we've actually been working with. You can see of 80% actually had of secondary and higher education. The higher education, these are 26% or 27% were actually university students, or university level. They had actually attained degree level of education. As you'd expect from our settings, unemployment was high, and the monthly income, the median was 5,900 shillings, so it's very, very low. And you can see we enrolled a majority from Kenya, but Kenya seems to be a safe haven for MSM from the region. There are some challenges across board. You can see many other countries represented: DRC, Burundi, Rwanda, Somalia, Tanzania, Uganda, and outside Africa. At least we were able to kind of reach a representative sample of individuals across board. And again, we were able to reach the population that we were targeting. At least homosexual gay from the group, it's 73%. Bisexual, 23.5%. And you can see a few who are not very sure exactly where they belong, which is still accepted, 0.4. And, we did both Swahili and English identities, and you can see very well representation in terms of the terminologies that are existing. So Kuchus and the Bashes and the Shogas and stuff. And as you expect from, and we found from other studies, about 28% actually had sex with women in the past 3 months. That's expected. And again, you can see 97.7 at least, or 98% were male, at birth. What I really wanted you to focus on is that at least we had 12.3% who identified as transgenders, and I'll come back to that particular population at some point, because we found something interesting about them. From the pool that actually we enrolled in the study, we realized that we wanted to find which organizations had actually been in contact with. But the way we had designed the study, we really wanted to make sure at least we target a general representative sample of individuals, of MSMs in Nairobi. We didn't want to kind of be overwhelmed by individuals already in the programs, and so the seat was carefully selected to kind of bring individuals who are actually not well represented in the studies or existing programs, and that actually happened. And you can see from this graph that 65% of the individuals that were recruited through the respondent-driven sampling had not been in contact with any other program. And you can see the other represented programs, Hoima, Easter, Liverpool, VCT, SWAP is also part of it. And but at least you can see we're able to touch a group that were not actually accessing services and were not accessing other organizations from before, which was actually a plus for us. In terms of results pertaining to the STIs, yes, HIV, prevalence is actually higher within this population. I mentioned that 32% among the sex workers, male sex workers, combined, like MSM and male sex workers predominating. But this population again is representative, and at this juncture, I'd like to say maybe this would be representative of the general MSM community in Nairobi, 26.5%. We've done very good, very well in terms of syphilis, 0.8, hepatitis B, 4.4, which is comparable to other studies we've done. Hepatitis C is creeping in and at 0.4. But we need to do something about gonorrhea and chlamydia, which seems to be an issue. You can see GC 4.5 in urine, 7.4 chlamydia, and either of the two 10.5. From the urine samples. Rectal samples, high rates at 18.1, GC alone 13.4, CT alone through the rectum 8.1. And we've not completed the oropharyngeal swabs, but at least you can see the ones we've actually tested, 2.8 have already tested positive for GC. None had actually tested for CT. But what I wanted to mention is that at least majority of these individuals who actually tested positive had minimal symptoms. They didn't have any current symptoms. So that means that at least the STIs have actually been pushed to the back burner and needs to actually be brought to the front. In terms of association with HIV prevalence, we did the crosstabs as expected. This is work from Adrian. He's actually the one who did all the analysis. Age, the older you are, the higher the higher risk that you are actually HIV positive. Education was protective as expected, or maybe it was actually a surprise finding. If you're Kenyan MSM, then you are 3 times more likely to be HIV infected. Sexual identity didn't kind of come out, like there was nothing significant. But you can see in terms of gender identity, those who identify themselves as transgenders actually had 2.2 times more risk of actually getting HIV. And I know we had issues with MSM saying that females are the ones who infect them with HIV. At least having sex with females was actually protective. That was an interesting finding. I don't know exactly what to do with, but at least it seems to be protective. And transactional sex at least didn't come out as it with HIV, being HIV infected. In terms of HIV testing history, in summary, what I wanted to say is that at least we had a very, a good representation of people who had actually been tested. 10.7 had not tested, or 11% had never tested. But at least you can see within the last 6 months, 56.6% or 57% actually tested. which is encouraging looking at that particular community with the stigma discrimination that they actually encounter. In terms of the settings where they actually went for the tests, you can see a very good representation of everybody. Like the public hospitals, private hospitals, community-based service providers, at the hotspots, community-based MSM services, and even at home. So most likely they're actually doing oral self-test. So I think to encourage more to be tested, we need to maintain these options going forward. In terms of in preference for future tests, again, you can see exactly who should be testing them. And by and large, what I'd like to say is that at least you can see everybody seems to be represented. And when they say doctor, I'm sure they refer to somebody who is actually, a nurse or a counselor or a doctor. Because in Kenya, those issues when people go to the hospital, everybody wearing a white coat is a doctor. And but at least you can see community-based MSM service delivery point seems to be very, very popular. And they seem to have an issue with hotspot testing, and that is something that maybe we might have to kind of look into. I also wanted to mention this self-test. So I think it's something that we actually need to look more carefully. Because it's creeping in and it needs to be, maybe we have room now to actually promote it. We have some results about PrEP. PrEP, I know Kenya is the second country to approve PrEP in Africa, second to South Africa. We've been talking about PrEP, a lot about PrEP from about 2 years now. But our PrEP cascade is actually not very encouraging from this particular population. I just want you to focus on this particular group. Out of the 412 who, in a way would have been eligible for, for PrEP and who had accurate information, who should have accurate information, you can see 206 had accurate information. So we need to do a lot in terms of demand creation. But you can see the cascade out of the ones should have actually been able to access PrEP. Only 57 tried. 44 had been offered PrEP, 42 had actually ever used PrEP, but only 2.7 were actually on PrEP as the study was actually happening because it was a cross-sectional study. So this tells us that we actually need to do more in terms of PrEP demand creation and promotion within the community if we were to make the gains that are required. So we had challenges in terms of knowledge and understanding of PrEP. There was confusion between PrEP and PEP, and there are few who have, had never heard about PrEP, and the whole issue of not really understanding how the medication could actually work. And you can see a quotation from one of the participants. I think PrEP, since it's free, I don't know if you used it before. I've heard of things, but never understood how it worked. Because why would you think? Why would you drink it not knowing what's going to happen during the day? Because you see the whole issue of anticipation of sex. One would say that if they will rape me, I don't understand, you drink it. There's a lot of confusion. One would say, what if they will rape me, maybe I should take it, I don't understand. And you can see the question whether you drink it. So you didn't know exactly how you actually take the pill. There were personal dimensions of PrEP acceptability, at least overarching views of PrEP were very positive in general. It actually might have an impact on the HIV epidemic if you actually do the right things at the right time, in the right intensity. But at least we have to actually address the whole issue of stigma around PrEP, because there is a little bit of that, and especially when people don't want to be seen taking drugs that could actually be confused with being HIV positive. So there was uncertainty expressed about PrEP, whether PrEP was meant for them. They thought PrEP was meant for people who had more sex partners than them, or maybe more sex than them. People who are meant to be riskier than them, and maybe sex workers. And so it looks like we really need to work on it, because individuals. The whole issue of risk assessment seems to be challenging. Individuals kind of think it should actually be meant, PrEP is meant for somebody else. And that is something that maybe requires a little bit more attention. So at least they're able to do self-appraisal and know with the HIV prevalence and incidence, high incidence among the MSMs, then they are all at risk of actually HIV acquisition. So again, most participants cited significant concerns for potential side effects. So that is something that we actually need to address. You can actually see the quotation about it. And we had actually 2 participants who actually started PrEP but then stopped because of side effects, and you can see a quotation about that. I am not going to read them because of interest of time, but at least the slides will actually be shared at some point. There was a social dimension, PrEP acceptability, and that's actually very, very important. Concerns how the others will actually perceive them if they see them taking PrEP. And the notion that PrEP use might indicate that they are actually more promiscuous, or they actually engage in regular risky sex. And the whole issue about taking PrEP being confused with taking ARVs for treatment. So and these are genuine concerns, and I think we need as researchers and clinicians in the program people, we actually need to address it and see exactly how it might actually be managed. So you can see the quotation, yes, in terms of them taking PrEP, yes, but I'm not comfortable with it. Why? My wife will ask me why I'm taking drugs every day. So the whole issue of maybe minimizing doses, the deeper PrEP might actually be very, very popular if we are able to look into it. Although the picture in terms of the cascade is actually very, very bad, there is hope at least. When we ask them in terms of PrEP, if PrEP was made available to you, how likely are you, would you be to use it if you were given the right information? And you can see very clearly 61% of the HIV negative MSMs who actually respond to that question, the 354, say they are likely to consider using it. So there is hope, and that is something that we might need to kind of continue promoting it within our population. Now we shift gears again to discrimination, which is everywhere, and these are things I've picked from the newspaper. This was a billboard on our roads on Thika Road, and it's kind of subtle discrimination, but it's actually happening, across board. And stigma, discrimination, and violence, and especially among the Kenyan MSM, you can see it's being perpetrated by everybody: family members, friends, healthcare workers, police, and the general public. And you can see the numbers, very, very clearly. Not all of them, not everybody had actually suffered discrimination, but at least you can see everybody is actually represented. And again, violence is also rampant. You can see physical assault, 16.4%, sexual assault, 10.2%, and this is very similar to what we're finding among the female sex workers too. But the Kenyan seems to be doing much better compared to the other MSMs resident in Nairobi from the other African countries. You can see the other MSMs from other countries who are actually resident in Nairobi for less than a year. You can see in terms of them suffering from stigma, discrimination, very, very, very high numbers, and this is something that needs to be addressed. And even if you're from other African countries and you've been in Nairobi for more than like 1 year, at least 1 to 5 years, the ones that we talked to, you can see there's a big significant difference between what the Kenyans are going through versus what the migrant MSMs are going through. So that is something that maybe needs a little bit more of attention. And my work is to actually make sure this information is out there, and maybe other people might actually take it up in terms of programming, because maybe this might actually go beyond medicine and HIV programming. Maybe something to do with the migration and how to treat the migrants, or maybe it could be something uniquely among the MSM migrants that needs to be addressed by the powers that be. Again, as I mentioned, we did PHQ-9, and depression emerged as an issue. You can see moderate to moderately severe to severe depression with PHQ-9 is about 17%. I know some individuals might say that PHQ-9 has actually not been evaluated, and in a way, customized for our settings, but at least we're using it, and using maybe the results as surrogate markers, then we know there is a little bit of mental health challenges within the MSM population that actually need to be addressed. And we also have a paper, a recent study done with Hoymas that clearly indicated there is a little bit of mental health challenges among the MSM that actually need to be addressed, and especially with the link with HIV acquisition. Substance use, especially alcohol, again, is an issue. About 10% really depend on alcohol. I think I would say they are, they are harmful alcohol dependent. And again, that is something that we need to address because it's at the beginning and we don't want it to actually worsen. But of concern, even if the numbers are low, substance use the last 12 months, you can see we seem to be having everything. In terms of the globalization, you can see we have ecstasy, speed, crystal meth, cocaine, crack, heroin, and people are abusing everything. The numbers are low, yes, but we don't want it to be 90%. We want it to remain low, or maybe even non-existent, because there's a very close link between these substance use and HIV acquisition. So the earlier we start addressing those concerns, the better. We also looked into the issues of online platforms, and I would say and the gay men, MSMs, socialize online in a big deal, and it's and you can see 71% confirmed they're actually active in the previous month, and others at least in the past year. But at least there is a small proportion that is not on the social platform. But I'm sure with time things will actually even out. Everybody will actually be on the social platform. Maybe these are my friends because I'm not on WhatsApp or anything. But at least I'm being forced by circumstances to actually go on social media too. But you can see in terms of representation, it's very clear that WhatsApp, Facebook, Twitter, Instagram, the general platform seems to be very popular in our setting. And the next slide kind of confirms that, which sites, which applications are MSMs using. And you can see Facebook, WhatsApp, and Instagram are very, very popular, being used by about 66%. My colleagues from Europe and Australia tell me that Facebook is used to, share pictures about food and family, family pictures, but in our settings, it's actually being mainly used for sexual hookups. And that is maybe a low-lying, hanging fruit, because this can actually be changed into our advantage in terms of maybe, information sharing and the like. There is a little bit of specific applications being used, and Grindr, what I would refer to as Uber for sex. At least, and Gaycom and Proto Romeo are actually being used by 22%. And lastly, the specific dating sites for MSMs and non-MSMs too. But you can see majority are actually on the general social media platforms. So that is something to think about in terms of maybe community engagement, reaching the individuals who are not reached, and even maybe edutainment, or maybe sharing health information through those social platforms. We also looked into frequent users versus all participants in terms of what will be significant. And the only thing that emerged is if you are high educated, then you actually use the social media more. But everything else wasn't significant. So age didn't matter, age group didn't matter, income, sexual identity, gender, HIV status didn't matter. So just education a little bit kind of influenced the use of social media. So, and this is true because 95% of our sex workers actually have a cell phone, and even in Majengo, where very majority are not educated, they still have the cell phones, and this penetration is actually very good. How are men using the different sites? So all sites can be used in a variety of ways: advertising, services, events, and we can actually use them for research. But you can see what the MSMs are using the social media for: meeting other MSMs, for company, connecting with other men in other countries. So we can continue. Sorry about that. Okay, thanks. Okay, so as I mentioned, there is an echo, Kevin. Okay, so as I said that, thanks. So the men are using the social platform for online friendship. They're also making friends prior to, like the physical contacts at the hotspots. So this is something that we need to look into. Again, there's an echo, so I'm waiting for Kevin to sort it out.
Hello, Dr. Kimani. Is there anyone else
I continue?
in the room with you? Is there anyone else in the room with you?
Kevin, do I continue?
A quick question. Is there anyone else in the room with you? I'm not sure you can hear.
Apologies for the challenge. Hello? 10 more slides and then we've finished. 10 more slides and then we've finished. Hello? Hmm. I know there's nobody in the room. I'm alone. I know there's nobody in the room. I'm alone. We proceed. Okay, it's actually on. Okay, so this is where it got stuck. So so they met, they make friends prior to going to the MSM physical locations for the first time. Those are the hotspots. There's an echo still. Okay, seems to have been sorted out. Okay, so these are the these are the things that are MSM are actually using, using the social media for in terms of friendship, and for sexual connections. Again, it's something that is actually very popular. So Facebook has there is a sexual dimension to it. People talk, they kind of connect, and we see exactly what's happening even with the generic ones like Klimani moms in Kenya, and people share pictures, and they organize sexual liaisons and etc. Grindr is actually very popular, and especially with the kids or maybe visitors coming to the country, it's kind of perceived to be for higher class individuals. The application for gay specific websites is actually using for selling sex. And again, it's these social interactions are actually used to kind of establish exactly who is who, bottoms, tops, and versatiles, but there are a few challenges that have actually been emerging about connecting online. There is, there are issues, although it actually makes, the meeting a little bit safer. There is a lot of blackmail in our region among the gay men. The pictures can actually be shared, and people actually they're being blackmailed by being threatened to actually being exposed. And within our society, then that actually dangerous, because majority of the family members don't know what is going on, and you don't want to be exposed online. So things can happen that that were not expected, and so there are a few challenges here and there, but at least as we continue, then they will be addressed over time. Then we actually looked at the cascade in terms of the 1990 among the individuals who are actually enrolled in the RDS, and from this data is actually very, very interesting, because this is, remember, these are individuals enrolled in other programs, or not enrolled in their programs, but at least they are even in the public sector. But at least you can see they about 71% were actually aware about the HIV status, and that's actually commendable, being a cross-section study. And out of the individuals who are HIV infected, 84% were actually on ART. And from the data that viral data that we actually collected, 83% actually virally suppressed. And that is something that maybe we need to look into, and maybe encourage them to actually continue, and maybe using all the platforms will actually be important. In terms of where they go, you can see there is a very clear distribution among the available options: public hospital, private hospital, and the MSM clinics, and very well distribution in terms of access to care. So currently, from this data, it's very clear that we actually need to maintain the options that are available. And And the issues that were raised is, some of the individuals who don't want to go to certain clinics because of being, just going to a particular clinic or even HIV clinics, and negative perception about MSMs and fear of side effects, and these are some things that we could actually maybe debunk by using the social media and maybe kind of doing more of demand creation. One of the objectives was actually to do population size estimate for Nairobi County, because this has actually been a very gray area. I know we've actually been using, hotspot geographical mapping and hotspot enumeration, I know we've actually used capture methodology. But for this very hidden population, our colleagues Adrian and Tim decided we could actually use the population multiplier method as an estimator, and using the available data in terms of membership into some of the gay community active sites and some of the service providers. Then we've actually been able to, and some of the service providers like LVCT, Liverpool VCT or Liverpool Health or something like that, or VCT Health. We've actually been able to estimate this population size of MSMs in Nairobi, and it's clear it's about 20,000 or so, at least 20,000 MSMs in Nairobi, and that's a big population because when you look at the individuals being addressed or accessing services now, currently is about 6,000. 6,000 maybe to about 7,000. So these are about 13,000 that cannot be accounted for. And looking at the HIV, prevalence and most likely incidence, that is a big number that is actually not being reached. And if we practice what we've actually been preaching in terms of not leaving no one behind, then we actually need to do more. These ones are the gay specific apps that have actually not been very, very helpful in terms of sharing the numbers, and this most likely will actually get in due course. We're hoping that we can get the numbers from Grindr, Hornet, and Pronomio, and maybe come up with like the population size estimates. And so this is ongoing, and we'll be able to maybe share this in maybe in one of the documents that we'll actually be able to publish. I'm almost done. Talking to, in general terms, talking to the MSMs, what will make your life better in Kenya. You can see their comments are very, very generic. It's like what everybody would actually see. Feeling safe, secure in my home and my country. That's normal. It just doesn't apply to MSMs only. Fair access to healthcare, that's normal. A boyfriend, a husband, someone to care about me, like that's generic. It's cuts across board. So these are people who actually have the normal ones, like everybody else in the general community. They also want to like to be employed. They want money, and you can remember they actually earning very little, 5,900 on median or mean per month. Economic security. So these are normal aspirations by everybody, being like it doesn't really matter whether you're gay, straight, or whatever orientation you are. Family love, support, and understanding. So these are general population that is really looking for us, to up to us. It's okay, it's a hidden population, but in terms of the aspirations in life, really resonates with us in terms of what they want. So I'm almost done. In terms of summary, then what I can comfortably say is that the RDS performed well and reached convergence on the key outcomes, and we actually enrolled a representative sample of MSMs in Nairobi. Could comfortably say that at least 65% were not actually receiving services from any MSM organization, and that is something that tells we actually need to do more. Community engagement and meaningful involvement of the community members was actually very key, and encourage everybody who plans to work with the community. This is the best entry point because it's actually very, very it's kind of it pays well and it's worth it. And as we speak, we continue engaging with the community. So in case there is a study or maybe a clinic I would like to start, I'm sure it will actually pick up because I still continue with the community engagement. Our team continues with the community engagement. High sexual health burden among the transgender persons was actually noted, and that is a population that maybe requires a little bit more attention. There's very little in terms of publications about transgenders in Kenya, and that is something that maybe we might need to look into. Mental health burden among the MSMs is an issue. Burden of HIV is high, and this is consistent with whatever we're finding among the other studies. So I know CAVI has some results. We're working with them. I think the HIV prevalence is about 26. HIV incidence is about 5, and even from the program is still about 5. Depression, alcohol misuse is considerable and needs to be looked into very carefully. There's this emergence of use of social media platforms being very popular, and I think we need to kind of use it to our advantage, and that is something that maybe we need to look into in terms of programming, and to work with this and reach this particular hidden population. And then care cascade test and treat trends look good, but at least we might need to kind of put more emphasis in terms of testing, because if 13,000 or 14,000 MSMs have actually not been reached, that is a group that we actually need to address. And at least comfortably now we can, in a way we have a rough estimate, at least 20,000 MSM reside in Nairobi County. And so it's not a population that we can actually ignore, and especially when you look at the HIV prevalence in that particular group. So in terms of conclusion recommendations, yes, there is a diversity of HIV testing options within the country, yes, but they're still required because many MSMs remain unreached, and we need options. Both public services, specific, private sector, and everybody need to be involved. We need to put more emphasis on targeted interventions, and especially for the transgender people. This is at least the first time I think I know from our data that has actually emerged. We need to continue promoting and demystifying PrEP, and this is cross-board, among the MSMs, and I know even the FSW, and we don't want to lose that momentum. Like in the programmers in terms of PrEP, we actually have to acknowledge and address the possibility of stigmatization of the PrEP users because of it's an ART. And health education is actually key to make sure at least we address the issues of potential side effects, and this could actually be very central to the rollout of PrEP to the general population. From me, I think use of generic social media platforms in reaching the harder to reach MSMs and even sex workers, engaging with them, using the platform to actually do demand creation for health services, for KPs. I think it's time we actually scale it up. And I think we have enough information that kind of supports that, and it would be foolhardy to actually not use that platform because it's a low-lying fruit or low-hanging fruit, however we look at it. Maybe that is something that we actually do pilot test and then maybe scale it up. But at least we know individuals actually on the social platforms. And I think that's all I had. I have I'd like to acknowledge a big team of supporters. The Nairobi Transform team, you can see it was a big team, led by Rhoda Kabuti. She kind of supported and kind of coordinated everything thanks to her, able efforts and, working, above, the regular time to actually make sure at least we remained in touch with the community. Adam, Peter, Elizabeth from from the London School and La Trobe. Adrian for everything that he did in terms of making sure at least he was able to look at the back end and see exactly what we were doing and help us to kind of reach out to the individuals even before they left the site. And the South African team led by Tess, because she was actually the one who invited us to join the study. And we did it together, and we'll be able now to compare the results between Nairobi and South Africa. And she was also able through EPSA to actually provide the money. And not the least, at least our community partners, you can see GALC represented very well, Ishtar, Hoimas, and the general MSM community. And I also like to thank the study participants and at least the money providers, EPSA, which was actually supported through MOT and DFID. And that's the last one. And in terms of, in case there's something that was not very, very clear, that's my email address, and I'm available to actually provide any additional inputs to whoever would want to hear more about the study as we continue with the analysis. So thank you, and appreciate everybody who participated in that, and hopefully that we'll actually have more to share in the coming days. I think that's the end.
Thank you very much.
Any questions?
Everyone can hear me. Thank you very much, Dr. Kimani. I think we can take one or two questions, maybe a few comments, probably in the interest of time. I can see we've clocked exactly an hour, and our session is supposed to be around an hour. So maybe participants, if you have any questions or any comments.
Kevin, how do we handle the questions? If at all there is any? I can see we are beyond time.
Yes. Probably you can take one or two, and then the rest.
Okay, so there's a question from Frida. Is the low utilization of gay-specific caps an indicator of self-stigmatization? I don't think so. I think some of these applications you have to pay and provide a lot of information. But I think the main problem would actually maybe if at all there is a joining fee or an access fee. Maybe that could be the bottleneck, bearing in mind that at least majority of these individuals are earning very low, 5,900 a month. It leaves very little in terms of flexibility. It could also be an issue of self-stigma because you don't want to be actually noted because you have to share a lot of information. That would be my guess in terms of why the gay-specific apps are not very popular. But if at all the generic applications are available and you're able to link up with your friends and hook up, maybe that is why it's not being used more here, because in the West it's different. But here we've actually started using Facebook and others to kind of reach out to the other community members. And so there was a question about the slides being shared. We will discuss that with the team, what we will do would be maybe share them as we actually do publications. So soon this will be available to everybody. That's what I like to say at the moment. So there's a question about having sex with female minimizes risk of infection. From the data, I didn't say it minimizes. You have to take precautions even if you're an MSM having sex with females. But at least from the data, having sex with females among the 30% who actually reported having sex with females in the past 3 months, they seemed protected. It doesn't mean it's free for all now, but at least in a way, I like to make sure at least it's very clear you need to use protection even if you're an MSM you want to have sex with a female. But at least from the data, it's very clear it was protected. I guess that should be the end, and we could actually continue discussion maybe in other platforms. Yes, I know social media is something that we need to look into more clearly, that is something that that's what I recommend, because the data is very clear. And if at all we're talking about evidence-based programming, then it would be foolhardy not to actually use the social media going forward in terms of our programming. So thanks everybody.
Thank you very much, Dr. Kimani, for your insightful presentation. Thanks as well to all the participants who joined us today. Any other questions or comments? I should be able to forward those to Dr. Kimani on a separate platform, probably through email. So you could continue to drop your questions or comments, and I will forward them to him later on, and we could probably give you some feedback as well.